So this course is about tackling cataract and glaucoma together, the twist and the turn. Many a times we get patients who have both the diseases, and we know both diseases have to be tackled together very nicely. Otherwise, we can land up in some complications. So in this session, we have cataract and trabeculectomy, refining the surgery by myself, Dr. Shalini Mohan. Then we have Dr. Colonel Madhu Budoria Madam from Sitapur. She will be talking about glaucoma valve and cataract, when and how. And then we have Dr. Sushmita Kaushik from Chandigarh. She will be talking about the tough nut, congenital glaucoma and cataract. We have Dr. Shweta Tripathi from Indira Gandhi Lucknow, and she will be talking about the newer glaucoma surgery, MIGS and cataract, the options and feasibility. And then we have Dr. Devang Ongmu from RP Center AIMS, and she will be talking about the dilemma of PACG and cataract. And then we have one keynote address also from Jakarta. So I will be starting my own presentation on cataract and trabeculectomy. So we can have three scenarios where cataract surgery alone can be done in the patients where it is mild or moderate glaucoma with controlled intraocular pressure or anti-glaucoma medication. Then we can do and plan combined cataract and trabeculectomy surgery in patients who have advanced glaucoma and uncontrolled IOP on AGM. Or there can be a subset of patients where trabeculectomy was already done and they have usually significant cataract, and then we have to perform surgery. So I will be dealing these two problems in subsequent slides. There should be some special consideration whenever we are planning surgery in these subset of patients. Sometimes there can be poor pupillary dilatation, for which we might be needing sphincterotomies, or pupil stretch, for which we need to have Coughlin or Sinskey hooks with us. We might be needing mechanical dilatations, so in our basket iris hooks or rings should be there. Inadequate anterior chamber visualization might be an issue, so better to stain the capsule, and anesthesia can be your per own choice. So whenever we are combining cataract and glaucoma surgery, there are potential advantages because it is a single visit for the surgery and therefore convenient for the patient. It avoids post-operative IOP spikes, and long-term IOP control is good. But then there are potential disadvantages also, like there might be more intraoperative and post-operative complications. Now, sometimes cataract surgery becomes challenging in such patients due to vitreous loss, and more inflammation is introduced, and combined procedures may be less effective sometimes also. So this is the combined surgery done from the same side for cataract and trabeculectomy. So this is superior phaco being performed and rhexis is being done as you do. Now after completing your capsular rhexis, it is important to keep your bottle height less because we don't want these compromised eyes to be under high IOP. Now I'm making a fornix based conjunctival flap, do minimal amount of cauterization to these patients, and this is a partial thickness scleral flap being made by the crescent knife as you do for your small incision cataract surgery entry into AC, and then phacoemulsification is completed from the same entry which you have made through your scleral tunnel. So entry should be of 2.8 if you are using a phaco tip of 2.8 or 2.2 depending on your own phaco tip. This I have fast forwarded. After completing phacoemulsification, you do thorough cortical cleanup. Now here it is important that the phaco parameters should not be too high, otherwise iris might prolapse because there is floppy iris. Then you insert the IOL through the same port and same scleral tunnel which you had made, and after that don't forget to put pilocarpine eye drops because the pupil should be nicely constricted because we have to do iridectomy. So once you are complete with your phacoemulsification, then you see the tunnel. Now you can cut the sideways of this scleral partial thickness tunnel to make a partial thickness scleral flap for further trabeculectomy surgery. Now after this you need to identify the junction of white and blue where you have to enter the AC and you have to do punch also. So this is the sclerostomy punch which comes into 0.5 and 0.75 dia, and then you can punch a nice opening over there. Now, if you're not satisfied with the size of opening, you can punch it again so that you have nice circular opening. It should be a regular opening, and from there you need to complete your iridectomy so that it doesn't come and block the ostium. Now, after completing your this thing, you have to suture the scleral flap. You can put releasable or non-releasable sutures depending on your own requirement or whatever you have decided for the patients. And once the suture should be nicely buried, and then you have to close the conjunctiva. Now, closure of conjunctiva is very, very important. We put two wing-shaped sutures. Tight closure is important. It should be a watertight closure so that the bleb forms nicely in post-operative period. Sometimes you might need to put a corneal suture so that if bleb is leaking from the cornea, it might not. So this I am putting a suture in the cornea and tightly securing the bleb. So now sometimes the conjunctiva might be overriding on the surface of the cornea. This is burying of the knots onto the cornea. If conjunctiva is overriding after you suturing, better to trim it to avoid any overhanging bleb formation, and then you can complete your surgery and check that the bleb is forming nicely in the post-operative period. So once you are happy about the bleb, then you can close your surgery. So this was same site surgery, but sometimes we need to plan a different site surgery also. So this is temporal phacoemulsification for the patient, and I will be doing a superior trabeculectomy. So cataract surgery is almost the same, nothing much about it. But once you have completed your temporal phacoemulsification, then you need to shift superiorly to complete your trabeculectomy surgery. I am putting a corneal stay suture because the exposure was not very good. So you can put a corneal stay suture with a Vicryl 60 and then make a fornix-based conjunctival flap, do thorough cauterization. In this patient, the bleeding was slightly more, and then complete your trabeculectomy surgery superiorly, same as we did in the previous case. So this was a trial, a good study of one-site versus two-site phacotrabeculectomy, a randomized study, and they found that both techniques yield similar result, but two-site group has less induced astigmatism and a better post-operative IOP control with less required anti-glaucoma medication. So the two-site surgery is better in long-term IOP control and in long-term requirement for anti-glaucoma medication. So we generally go for two-site surgery. Now, another instance can be where trabeculectomy surgery is already there and cataract has formed, and now we have to plan cataract surgery. So, in this subset of patient, there is you can see a bleb in the superior area and cataract is there. So, you have to reduce your phacoparameters because iris is very floppy, reduce the bottle height, reduce the aspiration and flow rate because you don't want any iris to prolapse outside. So, once you have entered the AC, you complete your phacoemulsification with your low end phacoparameters, and after that you can see iridectomy in the superior part also. Be in the central space because if you go too much in the periphery, you might catch the iris and can subsequently lead to iris atrophy or maybe in dialysis. So this is a routine phacoemulsification as is done. Now this is one interesting case where pupil was not dilating nicely, and this might happen many times after trabeculectomy surgery. Now we tried to stain the capsule, but it was the pupil was very, very small, and we tried to put high viscosity viscoelastic, but iris started prolapsing. So after repositing back the iris, what we planned to put two iris hook so that we can have a better visualization of anterior lens capsule, and iris hook placement, you can see after iris hook placement the visualization of anterior lens capsule was nice, and then the surgery could be completed. Now in such a case when iris is repeatedly prolapsing, then you have to be more careful regarding managing the iris. Now whenever I did hydrodissection, again iris started prolapsing. So after completing phacoemulsification, Under low parameters, it is not a bad idea to put one suture to secure your wound nicely so that you don't have any problem in the post-operative period. So this is the routine phacoemulsification being completed, and after that I have put one suture in this particular patient after implantation of IOL. Thoracortical cleanup is very, very important because these are already inflamed eye. We don't want inflammation to be more, and after removal of iris hook, this is IOL implantation, and then after IOL implantation, this is putting up a one suture. Now, in cases where you have poor pupillary dilatation, you can also plan to insert Malugin ring, or any other B-hex is also easily available with us. So you can put these rings, and they give very, very good visualization and comfortable area to work. And moreover, but you have to be very, very careful because iris is already compromised in such situation. So whenever you are removing these rings, you have to be very, very careful that the iris doesn't get entangled in the ring. Otherwise, it might lead to iridodialysis. So cataract surgery after trabeculectomy surgery increases the risk of trabeculectomy failure. So we have to be very, very careful. And if the duration between trabeculectomy surgery and cataract surgery is lesser or shorter, more are the chances of failure of trabeculectomy. And therefore, whenever you are planning, give substantial amount of time for between trabeculectomy and cataract surgery. So this is a small incision and trabeculectomy surgery, and here is small incision cataract surgery is being performed, and you can see I have taken this video from Dr. Sudhir because he routinely does SICS with trabeculectomy surgery. And after completing your SICS, then you can punch the sclera, the partial thickness ostium beneath the partial thickness flap, and this is after completion of your surgery, small incision cataract surgery. Then you can see that how this is the punch, and you can punch the ostium in the partial thickness scleral flap, and then complete your surgery by doing iridectomy. So that way you can combine your small, if you are a proficient small incision surgeon, you can also combine your surgery with trabeculectomy surgery, and then you must suture it nicely so that there is no leak in the post-operative period, and moreover you get good bleb formation. So this is completion of the surgery, trabeculectomy surgery, and then you can close the conjunctiva as we did for our phaco-trabeculectomy. So in post-operative period, besides antibiotic and steroid, it is important to use cycloplegics also, because we should keep the iris mobile in the post-operative period. So to conclude, I would say that proper pre-operative planning, good intraoperative strategies, and adequate post-operative management is important for successful surgery. Phaco versus SICS depends on the surgeon's own preference. Only trabeculectomy if there is no cataract. In combined surgery, 2 site is more preferable. Thank you so much for your kind attention. So with this, I would now move on to second presentation of this course, and I will be inviting Dr. Madhu Bhudoria Madam for her presentation on glaucoma valve and cataract, when and how.
How do I reach there? Next presentation, please. Madhu Bhadoria, just say that. Yeah, is there. Yes. Thank you. So very good afternoon, and I'm quite surprised to see people coming in. I don't know pre or post lunch, whatever it is, but it's a very pleasant sight. So she has covered, Shalini has covered basically all the baseline things. It's 12 minutes, bache. It's 12. Yeah. We got to guide them. So she has basically covered the cataract and glaucoma combined, the basic challenges. So from that I'll come actually. Cataract surgery actually, glaucoma surgery and cataract surgery combined have multiple variables. So important is conjunctiva is available or not available, glaucoma is primary or secondary, if it's secondary what is the cause, and then what are the IOP levels, are they very high, they are moderate, this thing, and what is the age of the patient, because we don't know for how long we have to manage the patient for how long, this thing. So if the conjunctiva is available, no big deal, Shalini has dealt with everything that is required, but now we are dealing with another situation. Now conjunctiva is not available. Now what can we do? So we can do a GDD, or the other option is that we can do MIGS or CPC. So there are two different spectrums altogether. One comes for the glaucoma when the pressures are not very high, and one comes when the pressures are high and you have other risk factors. So when to do a valve with cataract surgery? So basic fundamental is that in trabeculectomy we require conjunctiva where the valve can form, and second is we need to have a nice healthy anterior segment where the ostium can be made and it will remain open. So secondary glaucomas are often where the ostiums tend to close. And third thing is when we cannot really use MMC because of primary collagen disorders like high myopes and all that and other disorders. Therefore in them if the pressures are very high, GDD makes a very good option. So, lots of questions, people have this, that why will a GDD work when TRAB is not working? And in what way will GDD be a better option? So, if we look at these two blebs, the TRAB bleb is located right at the limbus and it's a thinner bleb, conjunctival bleb. Other bleb is a thick bleb and it's far away, so it's a safer eyeball. The other bleb is thicker, this is thinner, and the area is also, in the valve, the area is much bigger. So, if the IOPs have been high, to a significant level, it will control pretty well. And also they are relatively immune for blockade by iris, blood, or if the blood aqueous barrier is slightly leaky, they are affected lesser than the TRAB blebs are affected. So we see these examples of scarred conjunctiva, whether we have conjunctival diseases like Stevens-Johnson or advanced VKC, chemical injuries, multiple surgeries, or we have something like these war injuries where you have lots of these splinters and the conjunctiva is really awful. Pseudophakics, they really make poor patients for trabeculectomies, especially after SICS. You see this one patient who came to me for a PK, following us, this old patient came for PK, but actually the patient had very high IOPs, the valve was done and the patient was able to see. Similarly, like neovascular glaucoma, secondary glaucoma, so in this the ostium will close because of either blood or fibrin, or it will grow inside the ostium. So therefore, it's a good choice for a valve and not for trabeculectomy. Traumatic glaucomas and cataracts are often combined. And in them, actually, it's a real good choice because angle recession glaucomas are mostly difficult glaucomas to treat by a TRAB. You do a very good TRAB is fine, but otherwise, this is a good choice again. Then PK-related glaucomas. Most of the patients following PK will develop cataract because of loads and loads of steroids are pumped in the eyes. And then they also may be steroid responders. So in PK, I tell everybody, don't be a hero. Don't do valve and the cataract together. Here, do staged. And you can do it before or after depending upon the situation. If the IOP is pretty high, good to do a valve first and let it go and then do a cataract later. Same for refractory. So Sushmita is covering pediatrics, so I'll let go pediatric. And uveitic glaucomas are almost similar like NVGs, but in this you have very high peaks. So therefore IOP loss, so therefore the disc loss could be quite a bit and we can't even see the fundus. So that's where it helps a lot. Preoperative preparation, I think Shalini has dealt with. All I would say is here we are going to have usually inflamed eyes. Ocular surface will not be good. So control the inflammation of ocular surface, intraocular inflammation, if there is any systemic disease, and usually when you resort to a valve, pressures are pretty high. So menthol is a good option to give before surgery. Now how do we stage? Before cataract surgery, if the IOP is very high, glaucoma is pretty advanced and cataract is minimal, it's good to go for a valve first and cataract surgery later. If with cataract surgery, if this moderate glaucoma and other risk factors are there, like you have a uveitic glaucoma or a traumatic glaucoma, then it's good to go combined. And after cataract surgery, if IOP is not a big challenge, it's good to do just a cataract first and manage with medication. If they fail and you can't do a trabeculectomy, then go for a valve. So this is a video of a combined surgery. This is a patient of uveitic glaucoma. She is 35-year-old lady with intermediate uveitis, zipped up angle and very high IOPs. So here we'll be doing a Ahmed valve. So we make a deep pocket. The pocket has to be really deep and between the two muscles, lateral and medial rectus. And then I do this tunnel technique in which, now this is the valve is being primed. It's important to prime Ahmed valve because sometimes it takes a lot of opening pressure. It's different from the non-valve devices. And now we put this inside in the pocket. We make sure that at least it is 9 to 10 millimeters behind the limbus and not anteriorly, because whenever you keep the valve anterior, be prepared, it will move forward and the plate will get exposed. So here is a tunnel. It doesn't require any additional instruments. We make one small cut here, 7 millimeters behind the limbus. This keeps your thing also that you're not really too far or behind, and that plate is 10 millimeters behind. This is at the limbus, and nothing, using a simple crescent, we make a small tunnel in which the tube will fit very well, and tube will also be covered and there will be no sutures. So therefore we are avoiding the need for sutures also. And this at the limbus, why one doesn't go right in is because from here we can change the direction of tube. If we use only a needle, then changing the direction in the anterior chamber becomes difficult. So now we'll fix the valve. Valve is fixed always with non-absorbable sutures like a Prolene or a nylon. It's never with Vicryl. Just remember, it is an 8-0 suture and it should be tightly fixed because we don't want the anterior or the posterior migration of the valve. And both the eyes should be tightly fitted. There are multiple kind of sutures you can take, box sutures, this suture, that suture. The bottom line is the valve should not shake, because when the valve is slightly shaky, also sutures are loose, then there is a more chance of having hypertensive phase. So here now through this tunnel we pull this out. Just look at we are not having a straight vertical down the tube. We are just giving it a 1 millimeter turn, because a vertical thing always leads to tube erosion. So now we pull it back and now we enter here for the phaco. So standard temporal phaco, nothing really great about this phaco. I think it should go quickly. Yep. Usually uveitic cataracts are pretty soft cataracts. They don't really have nucleus. They just have one blob of opaque material. And then in uveitic cataracts, do not ever put a hydrophilic lens. Put a hydrophobic lens. If patient is poor, put a PMMA lens, because hydrophilic lens attracts a lot of inflammation. So once the lens is put inside, now here we don't evacuate the HPMC. We cut the tube of the desired length. And now we make a track inside the anterior chamber. So now here we make sure this track is parallel to the iris and not otherwise, so that it is as far away from the cornea as much as possible. Now through this we are going to insert this tube. This is 2011 video, so those days we were inserting in the anterior chamber. After that, most of us in a pseudophakic patient are now putting in the posterior chamber actually, and not in the anterior chamber. And then we fix the tube. We don't suture. The tunnel is not required, because tunnel is only a cover for the tube. It doesn't have any other purpose. So now we are going to fix the tube and close the conjunctiva. Conjunctival closure has to be as meticulous as it is for trabeculectomy. But here it's not a conjunctiva alone, it's a conjunctiva and tenon both. So both should be taken together, and not only the conjunctiva, because on the tube we need as much tissue as it is possible to be up there. So post-op, this is the post-op. It really did well because it was mostly posterior uveitis except for the glaucoma part of it. And quite a while later, this is the way it was. It was a really bad case, and it's been, I think, 13 years now. The patient is doing pretty well. I was worried about the corneal endothelial decomposition. Somehow it's not happened. So complications, the worst possible complication is hypotony and shallow AC. So this we can avoid by a tight tube fit. That is the code word. And we never leave the AC soft. We make it hard. And in case there is slight challenge also, we can leave some amount of Heron inside. The second is the tube migration in patients like this. So in this, this is the patient who's got a collagen vascular disease actually. So trap could not be done in this patient. In this, even the sclera melted. The donor sclera also melted. So really one has to think twice whether valve is the option in them or not. Tube erosion is a very bad complication because this is a ticking time bomb for endophthalmitis. So no matter how we do it, we do. Huh? 2 more minutes, yeah. It's 1 minute generally, no? So tube has to be covered, whether it's a flap, it's a sclera, it's a tunnel, it's whatsoever it may be, but it should be nicely covered to the extent that we have something nice sweet like this. So tube exposure has to be kept in mind. Initial phase is usually exposure, it heals, but later phase it does not heal, so let's not be in the paradise that it will heal automatically. Nothing will happen to her, we have to address it. Tube blockage like this can happen sometimes. So on the up here like that, if you use a 532 laser, it pulls out if it's a very fresh thing. But if it's not so fresh or it's more, then we can do a YAG with the lens. Tube cornea touch is to be avoided. If it is there, it is to be redone again. The tube has to be pulled out. An extender stroke a change of valve. Then tube retraction or long tube. Never consider a tube retracted unless and until you've done a gonioscopy, because many times an open tube sits in the angle and we are not able to see because of the corneal peripheral corneal opacities. This is that I talked about the tube exposure and all that. So take home is GDDs are very good devices, saviors in the face of odds. Cataract surgery can be combined before or after and used judiciously only on need, just not for a fashion or not for, I wouldn't use a word, not a nice word. Thanks. Thank you so much.
Thank you so much for this wonderful presentation. And you saw it was such a difficult case, but managed so well, my madam. We have another very difficult situation where we have congenital glaucomas, and then we have cataract, and we have wonderful expert from PGI Chandigarh, Dr. Sushmita Kaushik, to deal with it. So I would request her to present her talk.
Yeah. इसमें तो है नहीं. नहीं है नहीं इसमें. You want me to get the pen drive? पहले दिन पे ही सारे कर दिए थे, सिर्फ यही लोड नहीं हुआ. उल्टा है. This is an all women's IC ना? मेरा भी 12 minutes कर देना. आप कर दोगे? AIOS24. AIOS24. Yeah.
In the meantime, we can take some questions if anybody has some query. Any questions? So, Dr. Yeah, Madhu ma'am, I have a question. So, what about these non-valve devices, Barwald or Adi implant in such cases?
Technique is different. Outcome is same only.
Outcome is same.
The only thing is in limited corner, then there is a chance of hypotony, very high chance of hypotony. In them, the valve device is much better option. Otherwise, in NVG and others, the same. But Uvetic, I still feel more confident with AGV rather than the non-valve.
Any Dr. Shweta, madam? Yes, please.
Right. So, thank you very much, Dr. Shalini, for having me on your course. And of course, congenital glaucoma and cataract, we rarely find them together. but the outline today we'll talk about coexistent cataract, congenital cataract and congenital glaucoma. But then children can have cataract and glaucoma together, so cataract after glaucoma surgery and glaucoma after cataract surgery is also possible. Now, the first thing that would come to my mind is intrauterine infection, congenital rubella syndrome. That's the one entity which you should think of. The other rarer ones is a Loeys syndrome and a hereditary cataract with glaucoma. So this would be my thought processes when I see both. Non-acquired ocular anomalies, sometimes with aniridia and PHPV, you can see a cataract as well. So this, of course, is a rubella story. If you have eyes like this and you have high pressures and you have a cataract, the spot diagnosis is a rubella, congenital rubella syndrome. So we chanced upon it with newborn glaucoma. This baby was referred to us. We saw a whitish something under the microscope, and then we pulled in the UBM and did that, and that's really started our rubella story, and it made it to the cover of the Journal of Glaucoma because it was so rarely reported. So we prospectively looked at our newborns, infants less than 4 weeks, and the main thing that we found out was if you had a glaucoma in a small eye, which means no ophthalmos, a smaller cornea, and a smaller and a cataract, then you're looking at rubella rather than anything else, and these were the ones who were IgM positive. And the more important thing was that the cornea did not clear. So it's important to prognosticate if you get an IgM positive in them. The cornea does not clear despite comparable IOP reduction. So those on the right are rubella negative eyes. Neonatal onset glaucoma also does very well if you treat them in time, but you can see these at the same time periods, the rubella positive eyes don't clear. And the other important thing is systemic associations. We would never have looked for them, but 3 of them had a heart disease, 1 had a PDA which required surgery, and 1 had multiple problems, and 1 also had hearing deficit. So many times a lot of them are thought to be developmentally retarded actually, and developmental delay, but that's because we haven't got an auditory assessment and we haven't seen that they might be rubella. So our learning points really was a newborn glaucoma in rubella positive babies is possible. They are phenotypically different because they are smaller eyes and they have persistent corneal opacity because of rubella keratopathy, and that's not related to the raised IOP alone. And we need to screen for systemic associations like cardiac diseases and hearing defects. Now, we do have a small cohort who have hereditary cataract and glaucoma, which is not rubella. So these are babies with the ophthalmos and cataract who are systemically normal, and surprisingly none of the genetics has revealed a pathogenic variant. So I'm not sure what the pathway is. I've shared it with other colleagues in pediatric ophthalmology and genetics. So they can't seem to, unless it's Loeys syndrome, there's no real pathway which causes, or rather I should say known pathway, which is known to us, which causes ophthalmos and cataract. But they all come to us with that. The cataract is right in the center. Sometimes they don't affect vision as yet, but we watch it very, very carefully. Then, of course, you can have non-acquired ocular anomalies, known as aniridia. Often the lens is superiorly subluxated and then it's cataractus. So aniridia is a common thing. It's a bad glaucoma to have. Sometimes it's subluxated superiorly enough that inferiorly they are aphakic. We don't touch these eyes for the cataract. We would much rather just wait, give them aphakic glasses. They do well, let them grow a little bit, and then maybe the cataract can be out. So it's important to be judicious about what you're managing and not jump in to do things simply because it's there. PHPV is another conundrum. Usually it's in a smaller eye, but then it's usually unilateral, and we can usually see that on the ultrasound. So the next group would be cataract following glaucoma surgery. Of course, we are at fault many times. Most commonly, angle surgery, when you're starting off and you're not careful enough, you might, and this is one of the ones which I have done, you can see the needle track there. And always make the ports with the eye in the primary position and then tilt the head. That's something which we've learned. And cohesive viscoelastic to really, really push the lens back and make adequate space. And the third thing is always use pilocarpine to be able to constrict the pupil as much as you can to protect the lens. So it's also possible with the combined trap with trap. This is a baby who had this scarred cornea, and you can see on the UBM that little bit of a hole which has been created. So it's not a do all and be all end all. We need to be very, very careful, and we can sort of have a lens injury even after glaucoma surgery in these tiny babies. And then there could be glaucoma following pediatric cataract surgery. So that's the third. Now, who's at risk? We've learned that smaller eyes, less than 16.5 millimeter, and age of surgery. Now, this is something which has really come out, that if the age of surgery is less than 6 months and you do bilateral surgery and use of trypan blue, surprisingly, use of trypan blue is also associated with glaucoma following cataract surgery, and the number of reinterventions you do, I suppose, the more inflammation and the more likelihood of cataract surgery. And putting in an IOL has been implicated, that putting in an IOL in a small eye is not such a good idea, so we discourage that in less than 6 months. So once it happens, of course, there's no complacency, because the cataract surgery, once it's done, needs to undergo diligent EUAs, especially for IOP. It's not enough to say the visual axis is clear and the visual axis is clear and the visual axis is clear, but if you don't take the pressures, a lot of babies come to us like this. Now, if you already have a steamy cornea and a 0.9 cup, you've lost the battle. So you have to tide over a long, long lifetime. So that's the caveat that we've learned, that following cataract surgery, the glaucoma isn't. Just one thing, since we have the time, the reason why there's this age of 6 months is, remember, the trabecular mesh work develops till about 7 to 8 months after life. And the lens somehow is regulatory for anterior segment development. So if you take out the lens before 6 months, you are taking out a regulation of TM development, and that is thought to be the reason why there is so much more glaucoma vis-a-vis children who are operated later. And the other clue that has come out of this thinking is lens sparing vitrectomies. We used to struggle with glaucomas following PPL, PPVs for ROP. And ever since they've started lens sparing vitrectomies, because ROPs have to be operated very, very young. So once they started lens sparing vitrectomy, surprisingly, all the glaucomas have come down. So there is a thought in leaving the lens and letting the eyeball or the eye develop normally before we do anything. So of course, most of the management is medical, but surgery depends on the intraocular pressure and disc. Angle surgery would be wonderful as long as we don't open up the conjunctiva. A trabeculectomy, of course, a GDD, and then, or if nothing works, then a limited DLCP under transillumination. So I just like to finish off with a case which is glaucoma, though not cataract. So this is a recent child, and I'm awaiting genetics because I'll be very, I think her genetics has come. So she comes with 618 and 624 vision, about 3 years old, and 30 and 27, and stony hard eye, so the pressures are high. But the cup to disc ratio is not so bad. It's about 0.5 and 0.6, but absolutely shallow ACs. So we get a refraction done. We're already thinking microspherophakia. Sure enough, the refraction is minus 30 and minus 29. Now these lenses need to be out, even if there's not cataract. And this is something which Dr. Arif Khan has shown us. These are the anterior segment pictures. Children, cassia is a wonderful thing. We do ASOCTs in babies as young as 2 months, 3 months, and she is big. So this takes 30 seconds for a whole screen. So you can see these round lenses, and you can see that it's a pupillary block glaucoma. Nothing is going to work in this except doing a lens extraction. And the genetics is LTBP2. LTBP2 has been thought to be a gene for primary congenital glaucoma, which we think is not true, because LTBP2 and FBN are both zonulopathies. So it's the lens that needs to be out. Now, if you go in and do an angle surgery or something in this eye is going to be lost. So that's one thought that we've learned. The treatment is lens extraction. Just taking out the lens brought it down to 12 and 7. We left her aphakic as yet, and you can see how the angles have opened up. This is what the pupillary block was, and that's how the angles open up. So it's curative. So it's important to recognize that. I've just put this in to contrast LTBP2 to a CYP1B1. That is PCG. This is what LTBP2 is. LTBP2 will be clear cornea, large eyes, no harbs, very high pressures, no photophobia, because it's a collagen problem. So those are things that we are learning every single day. And always be alert. Another last, can I take 30 seconds more? Okay. So this father is aphakic. So he was scared about the daughter. Brought in, cataract detected early, infantile cataract surgery at 6 months of age, presented to us at 8 years, pseudophakic right eye, both eyes, right eye PCO, left eye buphtalmos, and pressures of 28 in the left eye. Now what was happening over 8 years? 8 years said visual axis clear, visual axis clear, visual axis clear. But it took 8 years for the disc to become absolutely glaucomatous and the pressures to go up to 28. And this is what the disc is like. So this is something which can be avoided if you just, there's no such thing as routine in any child. So in a nutshell, we look actively for a cause. Iatrogenic happens, glaucoma after pediatric cataract surgery is possible, and sometimes glaucoma needs lens extraction even without a cataract. Thank you so much. This is a shout out to my residents who work so hard day and night. Thank you, Shalini.
Thank you so much, ma'am, for extremely wonderful presentation and for covering such rare cases in such a comprehensive manner. Any question for madam? Or should we? Okay, so I invite Dr. Devang Ongmu for her presentation on primary angle closure glaucoma and cataract, dealing the dilemma.
At the outset, I would like to thank Dr. Shalini for the invitation and is it there? Connected? Ready? Starting? Okay. So I will be talking on primary angle closure glaucoma and cataract, dealing with dilemma. So we know what angle closure glaucoma is. The pathomechanism of angle closure has lens-induced and exaggerated lens vault, which is now confirmed also. So we have to see the role of lens. So the crystalline lens has a major role in primary angle closure due to pupillary block and exacerbation of the peripheral iris crowding. So it has been seen that in these eyes, they have thickened lens which are positioned relatively anteriorly. So that is why the lens is thick and they are anteriorly also. So that is why there is a very crowded anterior chamber as well as the crowding of the angles leading to closure. So therefore cataract extraction is beneficial in eyes with angle closure disease in cases where they have increased lens thickness, increased lens vault. And because of after the cataract surgery, it has been noted that there is an increase in not only increase in the anterior chamber depth, but also there is increase basically in the angle and the iridotrabecular contact area. So because the lens thickness that we are actually the cataractous lens that we are taking out are nearly between 4.5 to 5 mm versus a thin lens that we are placing, which is an average 1 mm lens. So that is why that area, that crowding has gone. So this is just a simplified outline wherein if a patient of angle closure glaucoma has cataract, so depending upon the stage of the glaucoma, whether the patient has mild to moderate glaucoma versus advanced. So if the patient is more towards mild side and the patient has a target IOP which is achieved, okay, so we would preferably do a phaco in that patient. If the target IOP is not achieved, then we can go for phaco with MIGS like GSL, BANG, ECP. However, if the disease is more towards moderate to advanced stage, we would like to go ahead and do a combined surgery or a stage surgery depending on the patient's eye status. So I would be coming to it. So what are the important things that we need to keep in mind in these patients? So in these patients, we know that these patients are smaller eyes, hypermetropic, smaller, narrow palpable fissures, shallow anterior chambers. They do have posterior synechiae, due to which there is poor intraoperative mydriasis. There is difficulty in dilating these patients because of the posterior synechiae. They usually have compromised in the endothelium because of the attacks that they have, the angle closure attacks, and also because of the age. And therefore all these high risk cases, there is a high chance of intraoperative and postoperative complications, and therefore these eyes should be done by experienced surgeon. So there are various complications like corneal edema. If the pressures, IOP of these patients should be controlled very well before you take the patient for cataract surgery. Never enter a eye which is high which has a high IOP, because there is a high risk of suprachoroidal hemorrhage in such eyes. So if lower the IOP, if there is a peripheral hydrocorneal apposition, there's a high, in these cases there are high chances of iris prolapse, and because of which there can be a wound side DMD leading to a complete DMD. There can be, because of the increased convexity, capsular rexus extension can happen, and once you take out that thick nucleus, these bags are usually floppy. So while taking out the last piece, many a times it so have happened that there is a PCR. So that is very important, and also the risk of suprachoroidal hemorrhage is also there. So the first and foremost thing is enter a soft eye which is the IOP is controlled. Second and most important thing is use of a very high viscosity viscoelastic to deepen the anterior chamber, and then we also have to use viscoat, basically a viscocohesive, to coat the endothelium, because these eyes are high risk. That is, we can follow the soft shell technique. We should avoid small rexes in these eyes because we want the nucleus to come out. So smaller the rexes, more the manipulation and more the inflammation and more the risk of complication. And there is a high risk of floppy capsular bags. So therefore we have to use very low phacoparameters. This is known as slow phaco. So this is just a surgical video wherein we can see that the patient is a case of angle closure glaucoma who is non-dilating and very shallow anterior chamber, nearly 0.9 mm. So we are using the help of iris hooks to dilate the eye, and then we are doing a capsular rexus. So once capsular rexus is done, you have to do a good hydrodissection and delineation. And at this point of time, you should remember that in hydrodissection, you don't have to do a very vigorous hydro, because again, if you do a lot of hydro, the entire blob of nucleus can just come up and lead to a sudden rise in IOP. So after putting the lens, the important thing that we should know is that whenever in very shallow ACs, we try and suture the wound, because there might be leak. So if you think that the wound is leaking, better to suture it. So we have seen that in cases of after angle closure glaucoma, after the phacoemulsification, not only the anterior chamber depth has opened up, the iridotubercular contact has also improved after the surgery. So this is the preoperative ASOCT, and this is the post-op ASOCT, where you can see that there is a widening of the angle also. The second is to do a staged operation. So what is staged phaco? So the stage is basically we do a phacoemulsification first, followed by trabeculectomy. So we all know that glaucoma filtering surgery, that is trabeculectomy, in patients with angle closure glaucoma, they have been proved to be associated with multiple surgical interventions, especially because of shallowing of the AC which happens, and to reform the AC and use of steroids, the cataractogenesis, there's a lot of cataractogenesis which happens, and just after within first year of trabeculectomy, we have seen that the rate of cataract progression is higher in these patients. So therefore, in patients who have very shallow anterior chamber, we can go ahead and do a initial cataract surgery in such patients. So in my opinion, PSEG patients who have very dense cataract or who have posterior synechiae in which a combined surgery cannot be done, or patients who can regularly follow up, who understand this thing of stage surgery, because again combined surgery has a lot of inflammation, and doing a stage surgery can help us achieve the target IOP. So if you are doing a stage surgery, we need to combine the stage surgery with a MIG surgery. So phacoemulsification alone may not effectively reduce the IOP to target levels in eyes where the trabecular meshwork remains occluded by peripheral anterior synechiae despite the anterior chamber deepening. So that is why we can use goniosynecholysis, wherein we are stripping off the peripheral anterior synechiae from the angle wall to restore the trabecular outflow. So this is just a small video where after doing a phacoemulsification, we deepen the anterior chamber with a visco-cohesive viscoelastic, then put the Swan-Jacob direct lens, gonio lens, and we can use a 23 gauge Healon cannula itself, or we can use a iris spatula, and we can just see that how the just gentle sweeping leads to the opening of this broad base synechiae. And once this synechiae is opened up, we can go ahead and do a bang also in these eyes, wherein we can strip off the abnormal trabecular meshwork. Here, we can see there's basically the arrow is showing how that strip of the trabecular meshwork has come out, and we just cut it and do a routine irrigation and aspiration. So we have seen that the phaco with goniosyneclysis have significant reduction in IOP, and in our series we have seen that the strongest predictor for decrease in IOP post surgery was the higher baseline IOP, lens thickness to axial length ratio, and patients who are having a higher lens fault. All these patients showed a better reduction in IOP. Then there's another procedure known as phaco-endocyclophotocoagulation. So again, endocyclophotocoagulation, one should know that the power being used is 0.2 watt, which is 1/10 the power of the DLCP that we are normally using, and that's why the side effect profile and the safety profile is much better. So if the patient cannot go ahead for a combined surgery, then we can do a phaco ECP in such patients. So in this, again, after doing a routine phacoemulsification, we after putting the lens, we just need to basically form the sulcus. We put a very high viscosity viscoelastic into the sulcus area after putting the lens, and not do INA, just put the viscoelastic and then put the 20 gauge probe into the eye, and then you can see the ciliary processes like finger-like projections, and aim each of the eye, and the end point is whitening of these ciliary processes. So initially they look brown, and as we are doing a photocyclocoagulation, they are getting white. So this can be one of the procedures. So again, it can be used in patients who have mild to moderate PSEG with cataract, mild to moderate PSEG in which the IOP is not achieved, and patients who are undergoing stage surgery. We need something to control the IOPs. And then is phacotrabeculectomy. So phacotrabeculectomy we reserve for patients who have PSEG with cataract, and basically advanced PSEG with uncontrolled IOP, and moderate to advanced PSEG also we would like to do a phacotrabeculectomies. So in phacotrabeculectomy, what, as Dr. Shalini has shown very beautifully, the important thing in this is that the rhexis should be of a adequate size. It should not be a small rhexis, otherwise it would lead to a lot of manipulation, and more the manipulation, more is the inflammation. Higher the inflammation, higher the risk of the failure of the surgery. And after this, we do a hydrodissection, and then we do a routine phacoemulsification, and this is a 2-site surgery. And then we do a routine trabeculectomy. What important thing is that depending on the eye, we can use a releasable suture, and we always have to suture the side port, which normally in routine phaco we don't suture the side port, but in this size you have to suture it. Otherwise the angle is shallow, and it tends to lead to the failure of the surgery. So at the end, I would like to say that management of patients of PSEG with cataract depends on the stage of the disease, whether the target IOP is achieved or not, the density of the cataract, the presence of posterior synechiae, and other risk factors. So treatment of each patient is individualized. One size doesn't fit all. Likewise, one surgery will not fit all. So patient, and lastly, but not the least, patient counseling for lifelong follow-up is important, because after phaco, many patients think that surgery is done, they stop the medications. So this is one important thing that has to be taught to the patients. And lastly, experienced hand is required in such diseased eyes. Thank you for the patient listening.
Thank you so much, Dr. Devang, for covering almost all the aspects of primary angle closure glaucoma and cataract, and very nicely depicting through various videos. And now we move on to next presentation by Dr. Shweta Tripathi. She will be talking about microinvasive glaucoma surgery and cataract options and feasibility.
A very good afternoon to all, and thank you Shalini ma'am for having me here as a part of the instruction course. So today we are just going to have a look over the cataract and MIGS, and when we plan to do it together, what are the options and how feasible it is to go ahead with that. So before that, let's have a look over the prevalence of glaucoma, which is estimated to be 66.8 million by 2040. That's a huge burden. So in only if we correctly diagnose and intervene, we are going to prevent that blindness induced by cataract, glaucoma. And the core concept, because of glaucoma surgery and the glaucoma treatment, is not only about the slowing down the progression by lowering the IOP, it's beyond that. That's maintaining a good quality of life for the patients, and for that control of the pressures. We go back into the history, and when we look back in 1960s, trabeculectomy was introduced in the field of glaucoma management. Until then, it's been the gold standard of surgery till there was a new beginning, because with the changing technology and the customization of the era coming up, because it came as an early recovery. So there, the new beginning was in the form of MIGS, that's minimally invasive glaucoma surgery, which gave us a freedom and liberty of choosing the IOLs what we wanted to do with our glaucoma patients. Because before that, choosing the premium lenses used to be really a taskful job because of the astigmatism induced by the surgery. So now this gives us an option of choosing the presbyopic lenses as well. So if we want to understand the MIGS, we can understand them in simple 5 features. It's ab interno approach. It causes minimal trauma to the target tissue with a modest efficacy, but yes, excellent safety and rapid recovery with minimal impact on life. So the advantages is, like, if your patient doesn't want to use the medication and at the same time he is worrisome of getting some complications with the glaucoma surgery to be done, this is the midway where you can afford your patient a control of IOP, and that can lead to a better tolerance, improving the adherence. So if there is so much good about MIGS, then what is the actual debate? It's about expensive, and yes, it's still in mist, though we are having some trials now which are coming up with I can say the results, but yes, the large RCTs are still awaited. Now coming to the options, if you want to just categorize the MIGS procedures, they are basically, you can start with the Schlemm's canal based, the subconjunctival filtration techniques, and the suprachoroidal drainage. And if you want to go ahead and choose the bouquet which MIGS is offering us today, let's have be a little practical, and what we are doing today would be the TM canal based procedures, mainly in the form of bang, KDB, which are the affordable ones, going with the iStent, then iStent Supra. When we go with the MIGS Plus, that is a bleb forming, that is this is a bleb forming procedure, that is we implant a Zen or a press flow, and last but not least would be the ECP. So what would be the ideal choice when it comes to the cataract surgery? So alternatives, they do have a comparative results when it comes to the different MIGS. So if we talk about choosing to a correct procedure, let's talk about the angle closure. My previous speaker has made my job much easier, because it's we can definitely go ahead and do a MIGS procedure in a case of angle closure glaucoma, which is well substantiated by the literature provided. And as basically this video I have put, because what is important is placing the patient's head and tilting the microscope. That is, if you would have seen, I have placed I've tilted the patient's head 35 degree away from me, and I have tilted the microscope 35 degree towards me, and that makes my angle visualization much easier. With that, we start with this procedure, where this was a gentleman who was actually posted for phacotrab IOL, but he wanted a sutureless surgery because he went through the literature and he said that he wanted a sutureless surgery. So this was amongst my initial MIGS procedure when I started, and I have purposefully kept this video because you see the problems which we are facing, like after doing a phacoemulsification and implanting the IOL, we put the pilocarpine you wash the AC, then you put the pilocup in, then you put a high molecular weight viscoelastic. Now cover the surface clearly, and now there is a placement of the swan Jacob lens. In the initial phases, I have kept some unedited part of the video so that the resident sitting here can benefit from it. See, this is visualization of the angle in the initial phase is definitely going to be difficult. The bubbles are there are corneal folds. So all these things are indicating that there is undue pressure which is being applied over the cornea. Now we put a iris spatula over that, and still the view is not clearer. So what we do is, there is a bit hyphema. So what we do is, we wash the hyphema again and again, not getting worried by that, and then yes, you wash the hyphema, and then again you reintroduce the viscoelastic, and now you see the angle view is much clearer. And now with a simple tweak movement, what is a tweak movement? Like to release the synecdoche, you tap it and then you do sideways movement, and this releases the synecdoche. This causes the iris to fall back down. Here it's going, and see the movement, it's sideways as well as a dabbing movement which is releasing the synecdoche all around. So this we did for this case, and we never went for any bang or any associated mixed procedure for this case. And to our very surprise, the pressures, they came out to be 12, and we had started with 30 with a 0.85 cupping, and still the patient is doing well despite it's been, I think, 1.5 years I have been following this case. So this is just a learning video which I wanted to share. Now coming to the as I have already said, that the RCTs are still awaited for the use of MIGS in PACG. But yes, when it comes to the MIGS, the first question comes in our mind is the affordability. So this bang procedure, that is a bent ab internal needle goniectomy, gives you the comfort of affordability, as well as you can start it with that. So there is not much of equipment which is required. So basically what you do is that you take a 25 gauge needle or a 24 to start with, whatever is available at your place. So to start with, what you do is that you visualize the angle clearly, and then you put a bent needle after duly filling the AC with a high molecular weight viscoelastic. Put some viscoelastic on the cornea as well, as we do in the OPDs. Now see, just put the tip over the TM, pick it up and just go ahead. And that's how your TM is being peeled off. And here, whatever the part of the TM was there which we peeled off, I'm taking out with the help of the forceps. So that you can do it clearly. And to overcome that, a more precise instrument had been launched in the field of MIGS, that goes with the KDB, as known as KDP. And as you can see here, it has got two blades here, and there is a glide here, and there's a sharp tip. So with this tip, you impinge on the TM, and there you just go. Simply, it makes your work very simple. Which we can see here in this video again. So after performing the phaco and implanting the IOL, you wash, put the pylo, constrict the pupil completely. And now again you put a high molecular weight viscoelastic, visualize the angle completely. And you see the difference, that how simpler and better it is. Because now you can visualize the angle, as well as you can simply go, and a simple movement ahead in to and fro direction peels out the TM. So here you can see that cleft being formed, and in the other direction as well. And simply what you have to do is, now we join both the things together, and simply it takes out your TM. You don't have to put any extra forceps or anything to wash it out or to take it out, and with that we complete the surgery. So now there are stents are also there, though the affordability is a limiting factor for these MIGS procedures. But yes, again, it's a smallest intraocular implant introduced, and here you can see it that it is very well being implanted in the TM itself. This forceps goes and implants it there. So, covering this and having said this, still the match which is made in heaven is still awaited when it comes to combine your cataract surgeries with the MIGS, and the choice totally depends on the risk profile of the patient. Surgeon's skill, you talk to the patient, give him the options, patient's willingness to undergo repeat glaucoma surgery, and the stage of the disease as well. And what would we do when we plan to start a MIGS? Because I'm sure that everybody wants to start with the MIGS. So there are certain questions which you need to ask to yourself before start the MIGS procedure. Why offer MIGS? You can definitely tell your patients that for moderate glaucoma, that's a sutureless surgery which is going to help you with the early recovery. The skills what we need as an MIGS surgeon would be a good intraoperative gonioscopy. Which MIGS should you start with? So first would be the canal based procedures. Should you offer more than one MIGS procedure at a time? Definitely a big no for the beginners to start with. The suprachoroidal space MIGS, though not very good for the beginners to start with, but later on you can start doing it. With now, which MIGS should I offer to which patients? So answer to that is that for all the open angle glaucoma cases, you go with the canal procedures, and the most important thing is an informed consent. Please go ahead with the informed consent, and whenever you're giving a discharge summary to your patient, that I have learned from my personal experience, please write that angle surgery has been performed. Now, pigmentation in the angle is really important to locate the TM when you are talking about doing a mix, and avoid mix if any inflammation is present. With that, we would conclude with a statement shared by Ike, who is the father, I can say, of MIGS, who said that these are the devices or a procedure designed to address the treatment gap that exists between the medical therapy and more aggressive traditional surgical options. So definitely, to conclude, I can say that yes, definitely the mix is there in the field of glaucoma management, but we need to choose it wisely, as it gives us a twofold benefit in long-term cost utility evaluation. Thank you very much.
Thank you so much, Dr. Shweta, for covering MIGS wonderfully well, and covering almost all types of MIGS and showing nice videos also. So next we will be having keynote address. In the meantime, I would request all the participants of this course to come for a group photograph, and I would invite Dr. Astrianda Suryono for her keynote address.
Okay.
Thank you. Good afternoon, everyone. My name is Astrianda Suryono, and I'd like to thank Dr. Shalini for inviting me, as well as all the organizers. It's my honor to be here. So I would like to talk about the glaucoma drainage device in Indonesia, and we did a little study in our center. So as we all know, that glaucoma is one of optic neuropathy that has a clinical feature of excavated optic disc with loss of peripheral vision and loss of retinal ganglion cell, and it is a progressive disease. So GDD is one of the most important surgical options, especially for refractory glaucoma that is unresolved by medication and filtering surgeries. All of my previous speakers have already talked about this, and the aim of GDD is to create a specific channel that can drain aqueous humor from the anterior chamber to the designated reservoir area. And the techniques and types of GDD placement is still evolving at this moment. So in Indonesia, at the moment, we only have access to Ahmed glaucoma valve. And we recently, well, maybe less than 10 years' time, we have this non-valved implant called the Virna glaucoma implant. The inventor is my dear colleague, Dr. Virna. And the Virna glaucoma implant is, by size, is not too big. It's similar to the Ahmed valve. It's a 14 mm by 11 mm device. And it is made from the PMMA, the body of the device, and with a silicone tube glued to the body of the implant. In the early invention of the tube, we can see that it's quite efficacious. The mean pre-IOP in the early days of early studies were 39 millimeter mercury, and during the 18 follow-up time, we can see that there's a significant drop of to 15 millimeter mercury, and also a drop of medication pre and post-operatively at 18 months. And the age for this patient group that we did a study on was 46 years old, and most patients were secondary glaucoma. Most of them are rubegotic or silicon-filled eyes. So the GDD that we use in Indonesia mostly indicated for primary glaucomas with failed trabeculectomy and other secondary glaucomas, including the neovasculars, the eyes with penetrating keratoplasty and retinal detachment surgeries, as well as traumatic glaucoma, uveitic glaucoma, and other syndromic eye diseases. We tried not to put GDD in eyes with severe scleral thinning, as well as expansive fibrosis in the conjunctiva. And in some cases, we put extra care in patients with vitreous in the AC and silicon-filled eye for GDD implantation. So let me talk about VGI a little bit. So this is the early studies that we did for the in the beginning of 2016, I think. So the bleb, as seen here, might look a little bit stretched out, the bleb wall. So mind you, this is a non-valved glaucoma drainage device, and the beginning of time that this GDD is introduced, we didn't do a tight ligation of the tubing. So it might look like this in the first post-operative period due to high fluid flow, and this is 60 and 90 days post-operatively. And this, in the beginning, we saw that there's a lot of hypertensive phases in the following months. So we start doing a no-flow ligating tube with Vicryl, and what we saw is the high IOP, but with less hypertensive phases later. So recently, we are still ongoing, we're doing an ongoing study, but recently we see a lot of exposed tube in some of the, in our cases, GDD cases in Indonesia. And of course, we know that this is a bad sign. It can lead to GDD failure and infection and, of course, permanent blindness. So we are not able to identify which risk factors or any factor that might contribute in the incidence in our population. So we did a study between the year 2020 to 2022 to see how's the proportion of exposed tube occurrences, and risk factors include age, gender, onset of the tube exposed, and diagnosis or type of glaucoma. Also, how about any previous surgical history and characteristics of GDD or tube fixation techniques. So this is a descriptive retrospective cross-sectional study done in our center in Jakarta. And we recruit patients with exposed tube during the period of January 2020 to December 2022. Sorry, it's a typo. And we exclude some medical records that are untraceable. We found a total of 693 GDD implant in this time, and found about 21 cases of exposed tube, which is 3%. And most of the cases happen in older adults of 14 years and older, with a mean age of 47. And there's no difference, that many difference between male and female groups. Most of the cases that has tube exposure are related to silicone oil-filled eye. And the duration of exposed tube from the initial surgery have a wide range of up to 4 to 148 weeks, with a mean of 33 weeks post-operatively. These are the history of surgery that the patients who has exposure had. Most of them had phaco-IOL, although we didn't manage to detailedly find whether it is a combined surgery or a sequential surgery, but some also have history of vitrectomy. Most implant that we use these days are the Verna glaucoma implants, so therefore more patients that have tube exposure is in the patients with the VGIs. The fixation techniques varied from scleral flap, pericardial graft, and scleral graft, but unfortunately, many of the studies were not documented well which fixation technique was done. But from the data that we are able to gather, some of the pericardial grafts has more chance of tube exposure. So I'd like to discuss maybe about the why this is happening. Of course, we know that conjunctiva health may have a huge part in this incidence, of course, and this is multifactorial, might be a cause of aging or degenerative, and also it may have a relation with pathophysiology of the conjunctiva itself, depending on what diagnosis or what disease that a patient has in the past, the past surgery and implant type, as well as the fixation technique. So in our study, it's maybe the incidence is not very different from previous meta-analysis done. So it's still between 0 to 12%, and there's no difference between gender, and the duration might be a little earlier than some of the available studies. So the patients in our case happened in the mean of 33 weeks or about 8 months' time. And the ones that have exposed are mostly older than 40 years old. This is, in some studies, it says that some younger patients have more risk of tube exposure, but it's slightly different in our side. And has a past surgery of vitrectomy, which is understandable. Probably this have an effect on the conjunctival health. In implant type, well, this might be biased because we do a lot of VGIs. So in these cases, we report more VGIs than Ahmed. And the fixation technique, although again not well documented, but pericardial graft is one of the more tendencies that has a tube exposure. So maybe in summary, I'd like to say that GDD is still one of the preferable options for refractory cases. And in Indonesia, vernal glaucoma implant is gaining more and more popularity because of its availability and it's more affordable. Tube exposure is a complication that should be avoided, and understanding its risk factor is advisable and can help us to do a patient selection. Tube fixation is a key, maybe the only one, or maybe one of the modifiable risk factor that we need to decide before the surgery, because it can predict the complication. And in our case, maybe pericardial graft is slightly higher than the scleral flap, so this might need a further study, but it's something to be think about. So that's it. I'd like to thank my colleagues who helped me put together everything, and I thank you.
Thank you so much, Dr. Suryono, from all the way from Jakarta, and presenting such a good study with big numbers, 693 cases. That was indeed wonderful. And I think next IC people are here, so we welcome them, and thank you everybody for attending.